I think maybe we will start. Can you hear me?
Yes.
Yes.
Okay. Did Puan ke Miss tak ingat. Miss Syahidah bagi tahu tak that tomorrow we don't have a lecture? Did she tell you that my lecture tomorrow is postponed to the next day? Did she inform you?
No, don't know.
No. She didn't. Okay, so tomorrow my lecture, there is no lecture with me tomorrow on pharmacodynamics. So it will be on Thursday, but I've forgotten what time is it. Maybe is it 11 ke? Something like that. And tapi it's not tomorrow. Tomorrow we don't have a lecture with me. So it's postponed because I have a meeting. So we postpone it. I'm not sure. I think maybe on Thursday, what time? That one I will inform you back if you have not been informed yet. So basically, I think I'm not sure whether to act like Asia or like MAS. And for Malaysia Airlines, they will wait for you and they will wait for you until everyone is on board. But for for Asia, they will even if the flight is delayed, I heard they will just you will not be able to go on the flight and once you are late. Okay, so I think maybe I will lock the meeting because of the sound. So basically, most of our lectures in RCMP are from 8 to 5. Rarely do we have lectures at night, like myself. Okay, not like other universities. Usually we don't tend to have lectures at night. So I'm just doing something different here. Okay, so for the past few months, sometimes I try something different and have lectures at night, just like other universities. Usually, which is not our tradition here in RCMP. Usually, our tradition is from 8 to 5. Usually, maximum 8 to 7. No, I think no one. Most in medical in the medical faculty, we don't tend to have any lectures or any classes after 5. I'm not sure about the clinical students. Okay, but during my time, of course, during as a clinical student, sometimes we have sessions at night with the lecturer. Okay. During my time, it was during orthopedics, etc. We had sessions in the hospital at night. But otherwise, mostly everything is conducted in the morning. So let's go on to the lecture. So today we're going to talk about pharmacodynamics. Okay, pharmacodynamics, drug receptor interaction. Okay, drug receptor interaction. So this is one of the most basic and very important topics in pharmacology. Okay, in general. So many students, they will struggle over the years to understand many topics in pharmacology. So one of the reasons for this is they did not really pay attention or they did not really master this topic. Okay, so it's very important for you to really have a good grasp of the basic concepts in pharmacodynamics. Okay, you need to really understand basic pharmacokinetics and also basic pharmacodynamics. Okay, because if you don't understand basic pharmacokinetics and basic pharmacodynamics, your journey with pharmacology will be very arduous, will be very problematic, very troublesome. Can you see my slides clearly?
Yes.
Okay. Okay, you just inform me if sometimes maybe I press something wrongly or something. Sometimes you will not be able to see anything. So I hope you can see things my slides clearly. Okay. Because so this lecture is being recorded, so I will upload as usual to YouTube, but it's unlisted. Unlisted means other people who don't have the link cannot are unable to view it. So I hope that you will click it once for a few minutes and then you can forget about it for the next, I don't know, until if you really feel that you need to watch it, then you can watch it. If not, you can just abandon it and just read your notes, books, whatsoever. Okay. So with regards to what you want to read, what you need to read for this chapter, actually I base my lecture mainly on Kazoo, but there is no harm for you to read any other book with regards to this topic. Okay, because for this topic, I don't think it's really necessary. It's very important for you to read a certain book because this is like basic stuff. So basic stuff usually they are the same. Whatever book you read, the concepts are the same. How they describe it may be different. How the examples that they give can be different. But mainly the gist, okay, the core information that is present in this topic is the same in any book that you read. Okay, but if you are confused about certain things, like maybe I didn't explain well, or maybe the diagrams that I showed was not clear. Okay, so you can go back to Zoom. But generally speaking, you can read whatever book that you want for this topic. Okay, because I will not say the same for every topic, but for this topic and some other topics, it doesn't really matter what book that you read. Okay, if you want to read a textbook. Okay, so preliminary knowledge, there is not much. Basically, it's just basic biology. Okay, your high school biology. Because you are still new, of course, we don't expect you to know a lot. So maybe a little bit of a little bit of biochemistry. Okay, so you need a little bit of biochemistry and a little bit of physiology in order for you to understand this basic pharmacology. Okay, so abbreviations that I commonly use. So C is for concentration. Okay. E is effect. Cl means clearance. Okay. Pk is pharmacokinetics. PD pharmacodynamics. What else? In this lecture, I think nothing else. I think probably there are no other abbreviations that I will be using. Okay. Sometimes I tend to use Malay. Because sometimes I think some of you might not understand certain things, so I might sometimes elaborate in Malay. Okay, but if you don't understand, usually it's not a problem because usually the things that I say in Malay it's not different from the what I've mentioned in English, except for it's just another way of saying the same things. Okay, so sometimes I will say certain things in Malay. Okay, so if you don't understand, if you really want to understand those things, you can ask your friends or if not, it doesn't really matter usually because one of the things that I mentioned in Malay usually are just jokes or anecdotes. Okay, so they are not really, they're nothing extra to whatever I have mentioned in English. Okay. Sometimes I show this picture. No, I don't usually tend to show this picture, but sometimes I feel that this topic is like it's like a toilet. Okay, in the sense that It's like a dirty kind of job. Okay, it's a dirty kind of job because this topic is a bit difficult. It's really a bit dry. So nobody wants to do this dry job actually. I don't take this lecture. Usually I give to our previous lecturer, Prof. Mohanty. He left for Manipal Medical College in Malacca. So usually he will take this lecture. I rarely take this lecture because I think this lecture is very dry. So I don't want to do the dirty job of. But someone, of course, has to do this dirty job of teaching you this basic sort of dry stuff, okay, of pharmacology. So usually I will push it to Dr. Mohanty, tapi but this year he's not around, so I'm taking this lecture again. Okay, I haven't taken this for quite a few years already, so but I'm teaching this back. Okay, do you have my slides or you already have I uploaded the slides?
No.
No. How about the previous one? Do you have the slides or I don't remember the introduction to pharmacology? I think someone messaged me, but I'm not sure whether your batch or the other batch. Did you get the slides for the first lecture?
Yes, we have that.
Oh, okay. Because sometimes I confuse with so many students in messaging me, so I sometimes don't remember which one is which. Usually it's inside it's in the VLE, but sometimes because they like to migrate, this VLE system usually it's there, but I don't know why. So our UniCal will migrate the system from one place to another every year or so. So when it migrates, so sometimes it's not visible anymore. Okay, so I have to like make it visible for you, or sometimes I have to re-upload the documents. Usually it's somewhere in the VLE, but where is it? That sometimes can be a mystery. So I have to maybe have a look at the VLE because nowadays students don't tend to look at the VLE so much. Like 6, 7 years ago, students will open the VLE every day. But nowadays, I think students don't really look at the VLE. They don't really interact with lecturers on the VLE compared to last time. Okay, because last time it was quite active. Students will ask me questions on the VLE and it's quite lively. But I'm not sure why. Over the past few years, the VLE has become like a cave. People just go there to download lectures. That's all. Okay, the students don't really use the VLE so much. Okay, so and we also maybe tend to use the VLE less nowadays compared to 6, 7 years ago in RCMP. Okay, drug receptors. So we have this thing called receptors. I think maybe some of you have learned this in biology. Okay, so this is just a basic concept. Even though it's basic, but I noticed that when I look at your seniors, I think many of them don't really understand, I think, this concept of receptors, and they really get things mixed up. So I can't really like recall a good example actually, how some of your seniors mention receptors, really, really weird, funny, bizarre ideas about receptors actually. Okay, when in exam, when we test them, usually they come up with all sorts of things. I can't really recall a good example, but I will try to think about some examples of how actually not understanding receptors can really affect your understanding of the whole thing. Okay, ini nampak sikit tak? Okay, now I can see my face a bit clearer in the screen. I don't know. Okay, so when we talk about receptors, okay, we talk about drug interactions with molecules in the patient. Okay, so this is pharmacodynamics. When we talk about pharmacokinetics, it's about the movement of drug in the body and also what the body does to the drug. Pharmacodynamics has got to do with the drug action in the body, usually involving receptors. Okay, usually involving receptors. So when we talk about drug interacting with molecules in the patient, so when the drug interacts with the molecules in the patient, okay, this will lead to the therapeutic and also toxic effects of drugs. Okay, therapeutic, for example, lowering of the blood pressure. Okay, lowering of your pain. Okay, lowering of pain, maybe reducing the pressure inside your eye, intraocular pressure. It can be increasing your hemoglobin. Maybe some of you, especially ladies, many of you are anemic. Your hemoglobin level is low. Okay, so your hemoglobin level is low, so we can give some drugs called hematinics to increase your hemoglobin level. So when your hemoglobin increase is called a therapeutic effect. Okay, or toxic effects. Toxic effects usually are unwanted effects. For example, you have giddiness, you become dizzy, you become nauseous, you have vomiting, you have diarrhea. Okay, maybe your respiratory rate is depressed. Your respiratory rate is impeded, it's hindered. Okay, it's being suppressed. So those are what we call toxic effects. So all of these happen because of the drug interactions with the molecules in the patient. So when the drug interacts with the molecules in the patient, so this will lead to the either the therapeutic and also the toxic effects of the drugs. So most drugs, okay, they will show their effect by binding, as I mentioned just now, by binding to specific molecules. Usually they are macromolecules. And they bind in such a way that it will change, it will alter the biochemical and also the biophysical activities of the macromolecules. Okay, so when the drug bind to the receptor, so that macromolecule, so the macromolecule will be changed, okay, biochemically and also or biophysically. Okay, so receptors, they are a component of a cell or organism that acts together with a drug and starts, okay, it will initiate the multitude or the multiple or the various events that will lead to the drug's observed effects. Okay, usually, secara simple ni, I mean, simplistically, usually we will draw it like this. We'll draw a receptor like this, just simple, or sometimes we draw it like we just do this. Okay. So we usually tend to draw it like this. Okay, so when we draw it like this, so usually this is supposed to depict, supposed to represent a receptor, okay, in a very oversimplified way. Okay, oversimplified way, we try to draw a receptor. Okay, so if you are really interested, you can go to YouTube and look at how people really draw receptors, how they draw using various either Adobe or other softwares, and how they try to how to depict the they are try to like make it easy for you to understand the various receptors. Okay, so drug receptors, so many have been isolated and characterized in detail. Okay, so and this characterization of the receptors, okay, have led to our understanding of the molecular basis of drug action in a more precise way. Okay, nowadays we understand because previously, okay, of course, like 100 years ago, people didn't really know about receptors, and they didn't know, have no clue whatsoever about receptors. But because of the advent I mentioned in science, so we are able to isolate. Okay, we can isolate the receptor, and we are able to look at it in more greater detail. Okay. Um, so some of the scientists will be doing this. Okay, they will study the receptors. Okay, in detail. Okay, they will isolate the receptor. Okay, for example, a specific receptor they will isolate it, and then they will really go into detail, study the receptor, and then use various drugs to test the effects of the receptor. So this is another way how we usually tend to draw a receptor. So the receptors, they really affect the quantitative relations between the drug, between the dose or concentration of the drug and also the effects of the drug pharmacologically. Okay, so the affinity, its affinity for drug binding influences the concentration of drug needed to form a substantial number of drug receptor complexes. So usually, we always talk about concentration and also dose. In when we talk about drug, either we talk about concentration or we talk about dose. In terms of correlation, of course, the concentration is more correlated. It's better correlated with what's happening, but we tend to usually use the dose because it's easier. Because dose, of course, concentration we cannot really measure sometimes. Okay, concentrations for some drugs we can measure, but also the concentration that we measure is not at the effect site. It's not at the real place of the action of the drug, but usually we just take the concentration from the blood, okay? And we try to predict what is the concentration at the effect site. For example, in the brain, if the drug acts in the brain, what is the concentration in the brain? We try to predict using what we call modeling. Modeling. So its affinity for drug binding that will influence the concentration of drug that is needed to form a substantial number of drug receptor complexes. And the number of receptors may may hinder, okay, the maximal effect a drug may produce. Okay, so that the number of receptors that you have can restrict the maximal effect that a drug can produce. Okay, so the receptor has a role here. Okay, and then receptors also will determine the selectivity of drug action. Okay, it will determine the selectivity of drug action. So the molecular size, the shape, the charge of the drug will be responsible, okay, for whether the drug will attach to a particular receptor or not, and also to what degree does that happen. So that will be determined by the receptors. And receptors also mediate the actions of pharmacologic agonists and antagonists, okay. And some drugs, okay, some drugs and also natural ligands, they will govern, okay, they will control the function of receptor macromolecules as agonists. Okay, usually as a direct result of binding to it, they will trigger the receptor to signal. Okay, so when I mention natural ligands, okay, so ligand is usually it's an ion, okay, or molecule that donates a pair of electrons to the central metal atom. Okay, usually ligands can be anions, cations, and also neutral molecules. So natural ligands, what are the examples of natural ligands? This one and this one. Um, I want you to type in the chat box. Type in the chat box. What is the H thing? And what is the N? So I mentioned natural ligands. So the examples, one start with H, when the other one starts with N. Okay, what are they? Okay, Hafiz mentioned hormone.
Neurotransmitter and hormones.
Okay, neurotransmitter and hormones. So one is neurotransmitter, the other one is hormones. So a number of agonists will stimulate one type of receptor, and that will cause the exertion of all their biologic functions. Or sometimes other receptors, other drugs will stimulate. Okay, other agonists will stimulate one receptor function more than another, more than the other agonist. More than the other receptors. Okay, so actually pharmacokinetics and pharmacodynamics, it will make more sense over the years. Okay, it's not something that you study today and you understand everything 100% usually. Usually that does not happen because your knowledge is still limited, and we will give you many examples, and these examples actually you will learn further in the next 2-3 years. Okay, so not everything will be clear to you. Okay, unless you are previously a scientist or something, you have done experiments on receptors, etc., and other things, drugs. If not, sometimes what is normal to happen is that you will understand 80-70% of this. Okay, and then over the next few years, your understanding will be better and better. Okay, if you continue studying. Okay, if you continue studying, your understanding will increase over the years, because the examples that we give, they are all drugs that we are going to teach you in the next few years. Okay, so because it's like the issue of course, like the egg and the chicken. So which comes first. Okay, so that's always an issue when teaching in this integrated system. Which one do we teach first? Okay, so because now your understanding, of course, of physiology and other things are still limited. So even if we give examples, you will usually not really grasp the example unless after so many years. Okay, then after many years, your understanding will improve over the years. So you try to understand as much as possible from what we have taught you, but then you have to understand that your understanding, of course, will improve over the years, because the examples that we give are examples that are taught later on. Okay, so that's the problem with one of the disadvantages of your system. Okay, that we are using compared to the traditional system of teaching medicine. So antagonists bind to receptors, but do not cause signal generation, and that will lead to interference in the ability of the agonist to stimulate the receptor. Okay, so generally in medicine, in pharmacology, we talk about agonist and antagonist. Okay, so agonist is something usually that causes something, causes the effect. Antagonist, it antagonizes the effect. For example, if I say in your heart, you have a receptor called beta receptor, beta 1 receptor. Okay, so you have a beta 1 receptor in the heart. So if I give a beta 1 agonist, your heart rate will go up. Okay, whereas when I give a beta 1 antagonist, okay, your heart rate will go down. Okay, so that's an easy understanding of agonist and antagonist. Okay, which will make more sense to you over the next few weeks and also months, maybe years sometimes. Okay, because some students they struggle more than others. Okay, so depends on your understanding and also your ability to understand things, and your effort, etc., will determine how much you understand and grasp these concepts. And then we have this what we call allosteric modulators. So these are drugs that bind to an alternative location on the receptor other than the area bound by endogenous ligands. Okay, so we have drugs, they bind to a location on the receptor other than the area bound by the endogenous ligands. Okay, endogenous ligands, as I mentioned just now, neurotransmitters, hormones, etc. Okay, so you can imagine, for example, in your body you have norepinephrine. Okay, it binds to the receptor. Okay, but so it binds to a certain location, but there are drugs that bind to an alternative location on the receptor, not the area bound by the endogenous ligands. Okay, so that's what we call, this group of drugs are called allosteric modulators. Okay, allosteric modulators. Okay, next, usually we talk about the macromolecular nature of drug receptors. So the drug receptors usually are proteins, mostly are proteins. So we have these various types of proteins, mainly regulatory proteins. So these regulatory proteins, they are the most well characterized drug receptors. Okay, means usually we have studied them a lot. Okay, we have studied them over the years, so we know a lot about them. So they are well characterized. Okay, so these regulatory proteins, they will mediate, okay, the actions of the endogenous chemical signal, okay, that I've mentioned just now, by the neurotransmitters, by the autocoids, okay, by the autocoids, and also the hormones. Okay, so autocoids are just usually molecules that act like hormones. Okay, they act like hormones, but they have a brief duration of action, and also they act near the site of the synthesis. Okay. So besides the regulatory proteins, we also have other classes of protein that have been identified as drug receptors. So we have the enzyme drug binding. Okay. So in this enzyme drug binding, so enzyme drug binding may lead to inhibition of enzymes. Okay. Example is the dihydrofolate reductase, which is the receptor for methotrexate. Okay, so some of you might have psoriasis, this disease of the skin called psoriasis. Maybe some of your family members, okay, or your friends have this psoriasis. Maybe you have some rheumatoid arthritis, joint disease. So usually for some of these diseases, we give this drug called methotrexate. Okay. So dihydrofolate reductase, this binds to the methotrexate. Sorry, methotrexate binds to the dihydrofolate reductase. Okay, so this dihydrofolate reductase, it's something that will be acted upon by methotrexate. And then we have this 3-hydroxy-3-methylglutarate coenzyme A, HMG-CoA reductase, which is a receptor for statins. Okay, it's a receptor for statins. Statins are drugs that we use to treat cholesterol, high cholesterol levels. So like we have simvastatin, rovastatin, atorvastatin. So those are the drugs that we use to reduce your cholesterol level. Okay, I think this one you have learned in biochem. Biochemistry, you have learned about 3-hydroxy-3-methylglutarate coenzyme A, HMG-CoA reductase enzyme. So this is an enzyme. And then we have transport proteins like sodium potassium ATPase. Okay, so this is a membrane receptor for the what we call drugs like digoxin. Digoxin is a drug that we use to treat arrhythmia, okay, abnormal rhythm of the heart. Okay, because a normal heart must have a normal rate and a normal rhythm. Okay, so your heart has got a rate and a rhythm. So your rate, for example, should be, most of you at rest maybe have a heart rate of maybe 50 to maybe 70, okay, beats per minute. Okay, but if your heart rate is all the time 110, 140, 150, of course, so that's a normal, abnormal heart rate. Okay, and then you have a rhythm, the rhythm of the heart, how the heart pumps, how the heart contracts. Okay, so that's called, when your rhythm is not normal, we call that arrhythmia. Okay, arrhythmia, abnormal rhythm of the heart. So one of the drugs that can be used, that we use sometimes to treat certain types of arrhythmia, is called digoxin. Okay, or it's a cardioactive digitalis glycoside. Okay, we call that digoxin, digoxin. Okay. Okay, and then we have norepinephrine, and NE is norepinephrine, also known as AKA noradrenaline. Norepinephrine, noradrenaline, they're the same. And then we have 5-HT, which is serotonin. I think you have learned from biochemistry lecturers. Okay, so we have serotonin transporter proteins. So they are membrane receptors for antidepressants. Okay, so the serotonin and the norepinephrine transporter proteins, so they are the membrane receptors for drugs that are used to treat depression. Okay, for example, we have venlafaxine. We have the SSRI, selective serotonin reuptake inhibitors, such as fluvoxamine. We have sertraline. So those drugs that are used to treat depression, okay, like major depressive disorders. So this depression are treated by antidepressants. Okay, and then we have these dopamine transporters. So these are the membrane receptors, the receptors on the membrane for cocaine. I hope you know what is cocaine. So what cocaine is usually known as a drug for rich people. Okay, cocaine is a drug for richer people. Whereas some drugs are more known to be abused by poor people. Okay, so cocaine used to be abused by many high performing people, okay, in the corporate world, etc. That's why when you see in many movies, and when they snort, you see the powder, that kind of powder on the table, okay, and then they put the something, and they will like that, So when they do like that, I think the white powder, so usually that is cocaine. Okay, cocaine. Okay, so cocaine is a very popular drug that is abused, okay, by many richer people. Okay, in overseas, especially in Malaysia, I'm not so sure how rampant it is, but of course in the US, okay, in the UK, so there are many rich people who are abusing cocaine, because it's a more expensive drug. Okay, so they will export. So people will smuggle it from Mexico, okay, and Venezuela, etc., Colombia, okay. So they will try to carry and smuggle cocaine, okay. And some Malaysians also get caught smuggling cocaine into Australia and other countries. Okay, so these are what we call the drug mules. Drug mules. In Malay, we call them the keldai dadah. Keldai dadah. They carry, and they will swallow it inside. They will put it in pellets. They'll swallow it, and then they will carry it on the plane. Okay. And then we have structural proteins, example tubulin, okay, which is a receptor for colchicine, which is a drug that is commonly used for gout. Okay, I think some of you, your parents, maybe your siblings, your relatives, okay, maybe your uncle, your aunt, okay, they have gout. Okay, so you have inflammation around the toe area. Okay, very painful, red after they eat some maybe seafood. Okay, so when they have this gout, they take some of the drugs that doctors can prescribe. It's called colchicine. Okay. Okay, I think this one you have studied as module forms 1. Okay, so I will not go into detail. So just to mention to you how certain drugs act, okay, and the receptors for it. So how did we identify receptors? What is an alpha receptor? So these things I will encourage you to read and you make your own notes, okay, because we don't have enough time. So this one just nice to know stuff sometimes. A relation between drug concentration and response. So the relation between the concentration, how much we give, for example, is it 10 nanograms per mil concentration? Is it 5 nanograms per mil in the blood or in the site of action, for example, in the brain, for example, is it 20 nanograms per mil or is it 30 nanograms per mil? What is the concentration of the drug? And also, what is the response that is elicited, what is shown by our body? Okay, whether it is a reduction in the blood pressure, whether it's our pupil size in the eye going bigger or smaller, okay, whether the pain reduces or not. So that relation is complex, okay? So usually in controlled in vitro systems in the test tubes, the relation is usually simple, okay, and can be described precisely with a mathematical formula. Okay, so in the test tube, it's easier to describe. But of course, what we see in the test tube is not exactly the same compared to what we see in human bodies or animal bodies. Okay, because of course, when it is inside the body, it is more complex. Okay, it is more complex, and the mathematical formula that we use might not be as precise when describing things that are happening. Okay, the concentration and also response of the drug. The relationship is not that well defined when we use certain formulas, okay, compared to when we use it in the test tube. Okay, so we have this what we call concentration effect curves. Okay, concentration effect curves, and also receptor binding of agonist. Okay, concentration is on the, when we plot the chart, concentration is on the x-axis, and the effect is on the response is on the y-axis. Okay, so the relationship between the drug concentration and effect is traditionally described by a hyperbolic curve. Okay, the hyperbolic curve. I think you have learned this in mathematics. In quadratics, etc., you will learn about the hyperbolic curve. So we have this formula, okay, E equals to Emax times C over C plus EC50. Okay, if I remember, I will try to upload an Excel file for you to play with this. Okay, because previously my supervisor, Prof. Richard Upton, he shared with me this file. Okay, so for me to understand this thing. Okay, so I will, if I remember, I will try to look for the file and upload so that you can play with this thing. Okay, so you can play with the various figures and try to understand the diagram, the curve. Okay, just in case you don't understand it. But if you can understand this from here, then you don't have to play with that thing. Okay, so E, okay, is the effect that we observe at concentration C. Okay, Emax is the maximal response that can be produced by the drug. So Emax is the maximal response that the drug can produce. I think I will show you a diagram later on. Okay, and the C, of course, is the concentration of the drug. EC50 is the concentration of the drug that produces 50% of the maximal effect. So if the maximal effect is like that, okay, so if the maximal effect is like this, so EC50, usually we will look at the this one. This is the EC50. Okay. So drug effect, drug concentration. So the relations between drug concentration and drug effect, like this. So this is the Emax maximum effect. This is the EC50, because the effect is this one, 100%. So at half, 50%. So at that 50% of the effect, you buat garis ni, you draw this lines, these dotted lines. Okay, using of course you can use Excel or whatever, Prism, or just using your hand. Okay. So you plot this and look at the concentration here. For example, this is 10, 20, 30, 40, 50, 60, 70 nanograms per mil or milligrams per mil, whatever. So the concentration here is called the EC50. Okay, EC50. So so this is the relation between the drug concentration and drug effect, or the receptor bound drug. Okay, so this one is if we plot this kind of receptor bound drug. Okay, so the receptor bound drug means, of course, the drug binds to the receptor. So that's what we call the receptor bound drug. Okay, means the receptor is bound. Okay, it binds to the drug, so it's bound. Okay, the receptor is bound to the drug. Okay, so if you look at this chart, okay, this graph, okay, so this receptor bound drug, if it is the maximum, okay, maximum binding, so this one 50% binding. So this one, for this kind of chart, we call this the KD. Here it's called KD. Here is the EC50. So the drug concentrations at which effect or receptor occupancy is half the maximum. So this one is called EC50. This one is called KD. Okay, but if you think this is confusing, then you just focus on this. Okay, some people find this one this part to be difficult. So if you find this one difficult, you just focus on understanding this. Okay, so if you have understood this, then you can understand this. Okay, because sometimes as a student, even as a doctor, usually we don't really have to understand this in detail. But if you want to read journals, you want to read articles, you want to have a better understanding of things, usually you have to understand this. Okay, so if you don't understand this means you cannot have a better understanding of how things work in this world. Okay, but if just to be a doctor, actually, to be honest with you, you don't really have to understand this stuff. Okay, usually. Okay, but it's nowadays our society, they are becoming more critical of us. Okay, more critical of doctors. They are criticizing us more. They doubt our judgment, our whatever we say about anything from vaccine to drugs, whatever. They don't listen to our advice anymore. So sometimes we need a better understanding of things. So we need to explain to them better. And for you to be able to understand and explain better to patients, of course, you need to understand things better. And for you to be able to understand things better, you need to understand these basic concepts in all fields, from anatomy, physiology, pathology, immunology, bacteriology, virology, mycology, and parasitology, and also pharmacology, etc. Okay, so you need to understand all the basic stuff for you to have a better understanding, so that you can understand things better and you can explain things better to patients. Okay. So we have the concentration effect curves and receptor binding agonists. Still continuation of that. So drug agonists, their action is by binding to or occupying, okay, a definite class of biologic molecules with a specific affinity for it. Okay, so this one I've explained to you a few times, so I hope you have grasped this concept finally. And this occupancy is assumption have been verified. Okay, so because scientists, of course, they used to because last time they didn't have very sophisticated equipments. They don't have the technology, so they don't really understand things. But they postulate, they hypothesize, they have theories about how things work. So, but what we can see is that this occupancy assumption have been verified. Okay, they do this radioactive kind of thing. Okay, receptor. So they use this radioactive receptor ligands in many drug receptor systems, and so this thing has been verified. Okay, it has been orang Melayu kata disahkan. The Malay say disahkan and verified. So it has been verified. Okay, has been authenticated by this radioactive receptor ligands. Oh, okay. I put a break here, but actually we are quite slow actually. So I think not sure whether you should have a break or not, because I think we are a bit behind time. But of course, I will not try to finish everything tonight. That's the good thing of why I choose lectures at night is I have more time, more leeway. Okay, I don't really have to rush things. So because the thing is, if I give this lecture in a very short period of time, I have to reduce the number of examples that I give. Okay, so if I reduce the number of examples that I give, you might not understand things. Okay, so for me to make you understand better, I think I have to give more examples, and I sometimes have to elaborate more than I used to. Okay, because when I think students struggle with these concepts, so I have to take more time. I will go slower. Okay, I explain the same things again and again many times, so that I hope most of you have a better understanding of things. Okay, because I know these things are quite dry. They are not super interesting, and they happen at a molecular level. Okay, so it's not something that many people will consider to be sexy or interesting. Okay, so that's why I know I have to go slow and give a few examples or more examples, so that I hope that many of you will have a better understanding of how things work. Okay. Okay. So next is we talk about receptor effector coupling. Okay, receptor effector coupling and also spare receptors. So when an agonist attaches to a receptor, so this will lead to conformational or modifications. Okay, modifications that happen in the receptor protein. So this will when you have this modification, okay, so this represents the basis, okay, the basis for receptor activation. Okay, and this is usually the first of the many actions. Okay, this is considered the first of many actions needed that is required to create a response pharmacologically. Okay, so the coupling is the whole transduction process that links the receptors, drug occupancy, and also the pharmacologic response. So just in case you have forgotten transduction, so signal transduction is the process, okay, the process by which a biological cell, okay, it converts one form of signal or stimulus into another. Okay, so this process of whereby a biological cell, changes, okay, the signal or stimulus into another form that's called transduction. Okay, transduction. Okay, so it's just some form of conversion. Okay, you can say conversion of signal. Okay, so that's what we mean by transduction. Okay. Okay, so this is our, I would say this is one of the most important slides in this whole presentation or lecture. Okay, this is something that we usually ask almost every year in exam. Okay, sometimes in OSPI, sometimes in the short answer question or modified essay question. Okay, so this is a very, very important drug, important concept, important slide that I hope you can redraw this whole thing. And don't print. I don't encourage you to print. I think it's better if you redraw or you trace, so that involves some some higher level of learning. Okay, compared to just if you just print out. I don't recommend you to print out. I recommend you to draw this back, write, copy this again, or summarize it, or paraphrase it, and then paste in your room. Okay, because this is a very popular question for Forms 2, I can tell you. Okay, this is a very popular question that we usually tend to ask in OSPI or modified essay question, or at least during single best answer or MCQ kind of question. Okay, so I hope you can really concentrate on this. So this is the agonist effect, or you can say the effect. So this is the maximum effect. This is the Emax. This is the EC50 for A, for B, for C, for D. You can imagine that these are actually drugs, different drugs. Okay, or you can or it's different situations. You can say sometimes. So this is a logarithmic transformed kind of diagram or scale. Sorry, graph. I hope you still remember what happens if we logarithmically transform a graph. Okay, it becomes a bit different from that shape to become more like that. Okay, it changes the slope of the graph. Okay, I hope you still remember from your mathematics that we sometimes transform the scale to become logarithmic. Okay, so the dose axis, so this one. Okay, so this one has been, we use a logarithmic scale on this axis. Okay, so this is the agonist concentration. For example, you can imagine this is 20 nanograms per ml, 40 nanograms per ml, 60 nanograms per ml, 80 nanograms per ml per milliliter in the blood or in the brain or somewhere. So the agonist concentration. So this is a logarithmic scale. Okay. So this is an experiment to show the spare receptors and also using different concentrations of an irreversible antagonist. Okay, so we have antagonist, this concept of antagonist, a drug that antagonizes. It can be reversible, can be irreversible. So this curve A shows the response of the agonist, okay, the agonist response of the receptor when there is no antagonist. Okay, so when there is no antagonist, the response is like this, super, maximum, maximum, and you just give this 20. When the concentration reaches 20 nanograms per mil, you get this. Okay, the EC50 is low. Okay, so meaning that you can use a low dose. Okay, and you have this concentration in the blood or in the somewhere in the brain, etc. Okay, so at that dose, you already have the EC50. Okay, you already have the effect, 50% of the maximal effect. Okay, So with the low dose, you get the 50% of the maximum effect. So this is without the antagonist. Whereas in curve B, we call this a curve that shifts to the right. The curve shifts to the right. Okay. This is when you give a low concentration, a low concentration of antagonist. Okay. You give a low concentration of antagonist, the graph shifts to the right. Okay. But the maximum effect is still there. Okay, you can see here, here, the maximum effect is still there. You can still see the maximum effect. But of course, you need a different dose. You need a higher dose. Okay, because you also give the patient an antagonist. Okay, when you give an antagonist at the same time, you need a higher dose. Okay, to reach the same effect. But of course, you still reach the maximum effect because of the available receptors that are still present. Okay. Graph C is compared to graph B is just when you give a higher concentration of antagonist. Okay, so you can still reach this maximum effect. Okay, but you need a higher dose. Okay. And then we have D and E. Okay. So it says here in curve C, produced after treatment with a larger concentration of antagonist, the available receptors are no longer spare. Okay. So in curve C, produced after treatment with a larger concentration of antagonist, the available receptors are no longer spare. It means there are no longer, we don't have any spare, okay, any extra receptors available. Instead, they are just sufficient to mediate an undiminished maximal response. Okay, still higher concentrations of antagonists, curves D and E, reduce the number of available receptors to the point that maximal response is diminished. So it's just saying here, if you increase further the concentration of the antagonist, okay, the antagonist, that will cause the receptors that are available, the spare ones, to become not available anymore. Okay, you don't have any more spare receptors, so your response, your maximal response is diminished. You don't have, you no longer can reach the maximal response. Okay, so for example, if I give you heroin, so usually your high level, you become very high. Okay, if your high level is 10, you are seeing, you feel like you are dancing on the skies, you are seeing musical notes. Okay, you feel really orgasmic, kind of heavenly kind of feeling. Okay, but then if you give a higher level of antagonist, so that the maximum effect is really very, very much reduced. So because of then there is no longer any, there are no longer there are no available spare receptors anymore. Okay, so that's what happens here, and also here. Okay, we have competitive and irreversible antagonists. Okay, I think we will continue tomorrow. Sorry, continue on Thursday. Okay, because I don't want you to be too tired to grasp this. So I will continue on Thursday. Okay, I will check again what time, and I will mention to you